He's a professor of medical oncology at the Edinburgh Cancer Research Centre at the University of Edinburgh, UK. Professor Cameron will give us a talk about the art of selection of chemotherapy in adjuvant setting of breast cancer.
Good morning. Thank you very much for the introduction. Thank you very much for the invitation to come to this wonderful country and this wonderful meeting and speak to you. I'm hoping there will be some slides to look at. Pointer. So what I will focus on is the question very much of choosing chemotherapy, not in the context of HER2-positive early breast cancer, because Eric has given us a wonderful talk around that important subject, but really focus on two questions. When should we give chemotherapy? And does it matter which chemotherapy we would then offer our patients? And I want to frame this in the context of remembering that the vast majority of patients whom I see, and I suspect many of you see, for adjuvant post-operative chemotherapy discussions may well already have been cured by their surgeon. And our job, therefore, is to find out which patients want to benefit from the use of chemotherapy to further reduce their risk of their disease coming back. And we need to remember that for each individual patient, usually a woman, there is a choice. We may recommend chemotherapy, but we know that they don't all actually need it, only some of them do. And what information do we have when we sit in that consultation? Clearly, we have a large number of important individual clinical trials. And I will mention a few of those this morning. They are focused usually on answering a specific question. Adding one drug, comparing two drugs, a particular selection of patients in the trial. We also have meta-analyses, particularly those conducted by the Oxford Group, which take large numbers of patients from many different trials. The advantage of a meta-analysis is it gives you a very precise estimate of the benefit of a particular therapeutic approach. But meta-analyses are very blunt, very ineffective tools for asking some of the subtle questions that we have to face. Is this woman's risk sufficiently high to justify chemotherapy? For her, what particular drugs do we use? So we have to balance the individual trial with more uncertainty and the meta-analyses with more certainty, but only on a population basis. And of course, as Eric has already alluded to in his talk, the characteristics of the patient will and should influence our choice. Somebody with a very significant cardiac risk is much more likely to suffer long-term effects from an anthracycline, whereas somebody, for example, who does fine needlework, concert pianist, somebody who uses their hands, peripheral neuropathy from a taxane may be more of an issue for that patient. So it's the balance between what the patient wants, what we know about the clinical data, and then some of the specific characteristics of that patient, which may influence our choice for her, even if it's slightly different from the majority of patients. And the information that we can get, mostly from our pathologists, terribly important role in the thinking around adjuvant therapy. The size of the cancer, the grade, hormone and HER2 status, whether or not there's lymph node involvement. From molecular biology, we have increasing access to multi-parameter tests, such as Oncotype, MammaPrint, Prosigna, and there will be more and more. And maybe in due course, although this is not really done in the early disease setting very much, we may learn more from next-generation sequencing, although at the moment that information doesn't help us particularly choose what adjuvant chemotherapy to give. So a lot of information that we have to distill down to make a recommendation for one patient. And I think the two key questions are, first, Do they need any adjuvant therapy? And the vast majority of our patients will get it, even if for many it's just hormone therapy, which is not the subject of my talk. And critically, I want to look at, do they need chemotherapy? And if so, does it actually matter which chemo? When does it matter? And when is that less important? So let me frame this around a particular question, because this is the one I think most of us find the most challenging. Does every woman who has a hormone receptor positive and primarily HER2 negative breast cancer, when does she benefit from the addition of chemotherapy to good modern endocrine therapy? And for most of us, the starting point of that discussion is if her risk of a distant recurrence, because distant recurrences are much more dangerous than local recurrences, is, say, more than 10%. That's the kind of setting where we start to think, shall I give you chemotherapy? Or actually, are you someone for whom chemotherapy is not really indicated? And I will frame this around these 4 questions. Do we have tests that tell us that this cancer is sensitive to chemotherapy? Not its risk, but its biology. Equally, given that we're adding chemotherapy to a background of good hormone therapy, do we have tests that says this cancer is beautifully sensitive to hormone therapy, so we don't need chemo? Does the age of the woman matter? I'm aware that in much of the Middle East, your average age of patient is younger than what we see in Western Europe and North America. So age is a more dominant feature in your discussions. Is that a driver for selection? And then this really important question, which sits there for most of us trying to work out. For the luminal A breast cancers, there is a story that goes around, which is that they are not sensitive to chemotherapy. Just how good is that evidence? So let me take the first one. And I think the most encouraging data as to whether there is a test that predicts for chemosensitivity comes from the use of Oncotype DX. However, I don't think this yet proves chemosensitivity, and I'll explain why. The best data comes from an old trial, but a more recent analysis done by Kathy Albane on the INT-0100 trial, which had nearly 1,500 patients randomized between 3 arms, of which only really 2 are important to this question. Tamoxifen alone, chemotherapy with CAF, so it's an anthracycline, followed by tamoxifen, and then there was a 3rd arm where the tamoxifen was started with the chemotherapy. And over on the right, you can see that those women who got chemotherapy followed by tamoxifen had a very significant improvement in overall survival. So chemotherapy does work in this trial. What they then did was to do a biomarker study using Oncotype DX to ask if the Oncotype DX score could be predictive of the benefit of chemotherapy. It's seen overall. Can it identify those women for whom it doesn't work? The first thing to note is this. The number of women in this is much smaller than the original trial, even though, of course, it only looked at 2 arms. And this is what was published about 3 or 4 years ago in Lancet Oncology. In those women whose Oncotype DX score on their tumor was low, there seemed to be no benefit from chemotherapy. If anything, the tamoxifen alone arm is slightly higher, not significantly different. In the intermediate group, no statistical significance, but the chemotherapy arm is coming out slightly on top. And in the Oncotype high score, greater than 31, very clearly the women who were given the chemotherapy as well as tamoxifen did better. And there is, in fact, a positive interaction test, suggesting that this is a real difference between here and here. So does this prove that only those with Oncotype DX score high should get chemotherapy? Well, as with all evidence from a single study, you have to weigh the evidence. The strengths is that it was a properly conducted prospective randomized trial, and then obviously a retrospective study. And the translational research was done according to agreed international standards. The design of the statistical analysis was planned before they had any data. So they weren't making it up as they go along. And the outcome data are mature, 10 years of follow-up. The problem is, less than half of the patients in the original 2 arms could be included. Not deliberately, it was about getting tissue. So we don't know that their biology is the same as the other 60%. The problem I really think is most important is this. In the low group, the hazard ratio, the confidence intervals, so what the statistician says is the likely range of truth, ranges from chemotherapy halving or doubling the benefit. So in other words, chemotherapy could be worse or better in the low group, and that's purely down to small numbers. The trial also is only in postmenopausal women, and many of us want to use this in premenopausal women, and it only used DFS, which includes local recurrence, whereas it's distant disease-free survival that we probably are more concerned about. And, being an old trial, there were no taxanes. So I think it's very provocative. It suggests, but to many of us does not prove, that Oncotype is a chemotherapy predictor. In the same study, another analysis, without using Oncotype DX, looked at HER2 and ER scores, and you can see here that the group who got the benefit were those who were HER2 positive or low to medium ER. Arguably easier and certainly cheaper to use. And when they did a multivariate analysis, the only thing that comes out was having an ER score in the low to medium range. So two different things suggesting we can identify the chemotherapy-sensitive patients. Either Oncotype DX, not proven, but quite strongly suggestive, or an ER medium to low score. Again, a single study, so not proven. It suggests there is a chemotherapy sensitivity predictor, but we're not quite sure that we've got there. What about hormone sensitivity? If you could prove that this patient's cancer was going to respond to hormones, then maybe chemotherapy is less effective. Other than the hormone receptor status, there isn't really one, but I think we will get it in a few years' time from this very interesting trial run by Ian Smith and Mitch Dowsett at the Marsden, which has completed recruitment in the UK. 4,000 postmenopausal women with operable breast cancer were randomized to get either 2 weeks of an aromatase inhibitor and then their surgery, or just their surgery. They then go on to get completely normal endocrine therapy, etc. afterwards. And the question they're asking is, if you look at the changes in the Ki67 and or other molecular characteristics induced by 2 weeks of therapy, is that a predictor for very good outcome? In other words, maybe the test will not be something your pathologist tells you at diagnosis, but something your pathologist tells you by comparing the core biopsy at diagnosis and then what the cancer looks like after a brief exposure to endocrine therapy. It would be wonderful to say the women whose cancers respond in 2 weeks at a molecular level then don't need chemotherapy. However, we don't know that that is true. What about age? Well, it's difficult because I couldn't find any very good data that asked the chemotherapy question in age. But if you look at this publication from Michael Gnant and the Austrian group, which was asking an endocrine plus or minus bisphosphonate question, in premenopausal women, okay, and they were reasonably good risk premenopausal women, 3/4 were T1, 2/3 were node negative, and 80% did not have grade 3 cancers. All they had was endocrine therapy plus or minus a bisphosphonate. They have a very good outcome with endocrine therapy alone. So good prognosis cancers in premenopausal women, including some young women, still do pretty well. Clearly, there are bad risk young cancers, but not every woman, because she's young, necessarily has a bad risk cancer. We need to take other factors into account. So what about this luminal A story? How good is the data? So, question to the St. Gallen panel 4 years ago. I wasn't on the panel, but you can see lots of well-known people sitting there, some looking more interested than others in the question. What do you do with luminal A cancers? Would you give chemotherapy to every woman who has a node-positive cancer, or do you exclude the luminals? And so they broke this panel discussion down into a shorthand or simplified molecular classification. And the group we're interested in is the luminal A's, defined as hormone receptor positive, HER2 negative, and here they took a low Ki67. Would you give them hormone therapy alone, even though they have nodal involvement? And the panel could not reach consensus. So approximately 50-50, some would give chemo to all, some wouldn't. So how do we deal with this? Well, one of the first problems is how you define luminal A. It's clearly a subset of hormone receptor positive patients, and it has been defined differently in different studies. High ER, low Ki67, low score on the MammaPrint or Amsterdam signature, or low score on the Oncotype. And we don't know that these pick out exactly the same cancers. They clearly pick out lower risk cancers, but the overlap between the definitions is not being well studied. So that's the first problem. How do you define your luminal A? And then if you go and look at the Oxford Overview data, so this is asking questions in very large numbers, ER-positive patients looking at randomized trials of chemotherapy for breast cancer mortality, they can't find a group in their data set that don't benefit from chemotherapy. Whether the ER is low to moderate with the old biochemical score or high, whether the women are younger or older, whether the cancer is poorly differentiated, generally speaking grade 3, or well differentiated, which includes many of the luminals. The hazard ratios line up. Chemotherapy in the Oxford Overview dataset appears to benefit them all, irrespective of these categorization issues. And even in the taxane dataset, so I'll come back to it at the end, the same is true. And interestingly, although this is not significant, the group with the best benefit from taxanes include the luminal A cancers. So this doesn't prove that the luminal A being insensitive to chemotherapy is true. Doesn't mean it isn't, but the data are not pointing towards that. We have to remember that these are older studies. Most of the ER was done biochemically, which has issues, rather than the modern quantitative immunohistochemistry. So it doesn't mean it isn't true, but it doesn't support that thesis. And the other thing to remember, of course, is if you're going to rely on Ki67, and I'm aware there are pathologists in the audience who know more about this than me, it really matters how you measure it. And there are, and this is an example of one paper from JNCI, international groups who've sat down together and tried to define exactly how Ki67 should be measured. Because if you measure it wrong, you get the wrong answer. And this is something that perhaps hasn't been as well standardized as some of the other markers. So go cautiously into the area of defining your luminal A and concluding that they don't benefit from chemotherapy, bearing in mind that their overall risk is less. So what would we do in Edinburgh? We don't use genomic tests. We tend to use a shorthand molecular approach, and that's fairly common across much of Western Europe that I'm aware of. For a luminal B cancer, if it's node positive, we will almost certainly offer the woman chemotherapy. If it's node negative, we'll pick out those with high grade. Obviously, if it's a very large cancer, T3, for example, that will modulate the risk. But it's all driven by risk, not because we believe we have a chemotherapy predictor. In the luminal A, node negatives, we very rarely offer them chemotherapy. They're very rarely large cancers. And in the 1 to 3 group is really where we end up having a debate, and there is no clean answer. And yes, in that subgroup, it would be nice to have another molecular test that helps us pull it out. But those molecular tests are still mostly about risk rather than chemotherapy sensitivity. And bear in mind, this is data from one particular study in Edinburgh, but study after study after study after study always tells us something. The number of involved axillary lymph nodes is a very, very important risk factor for prognosis, but not predictive for sensitivity to the therapy. It's just about risk. So this risk has to be taken on board in balance with the patient's desires and the toxicity, which is why it's never an easy situation where we can define a precise algorithm about what to do. If you're faced with a patient who doesn't want toxicity, do we just reduce the doses of drugs? Well, probably the best data come from the anthracyclines, and the answer is if you reduce the doses, you reduce the benefit. We have really 2 trials, a French trial with 2 different doses of epirubicin, and a US trial with different doses primarily of anthracyclines, but also cyclophosphamide. Less toxicity with adjuvant chemotherapy usually means less benefit. It's not often worthwhile to do it. Being kind with doses is not being kind with outcomes. What about with taxanes? So I'll come on to the Oxford overview data, because most of the trials we've done have added taxanes to anthracyclines. But this US oncology trial of AC compared with TC, in other words, where the taxane is substituted for the anthracycline, is giving us a suggestion that actually TC is at least as good as AC. Obviously, in the data on the slide, at 6 years, in fact, the figures were more favourable for TC. And so there are circumstances where we will substitute Taxotere for an anthracycline if the patient has a high cardiac risk. Choice of taxane. There are lots of reasons to go for Taxotere, and there are other and equally numerous reasons to go for weekly Taxol. It depends on a whole lot of things in your local circumstance as well as the patient. The only really good randomized data come from this ECOG study, which in fact was not designed to compare weekly Taxol with 3 weekly docetaxel. And updated data were presented at San Antonio. But essentially this trial suggests that weekly Taxol is as good as 3 weekly docetaxel. Might be slightly better on this graph, but there's not much difference statistically. It's a choice in terms of frequency of visits, types of toxicity, and so on. But if you're going to give a taxane, the data suggests you can use one or other. Let's go back to the overview analysis for the last few minutes, because this gives us a measure of just what benefit taxanes offer and allow us to ask that other question, which has been suggested by some studies, that there may be subgroups where the taxanes are more efficacious and there may be subgroups where taxanes add much less. So in the Oxford overview data, you can see here the data from the trials was split. So these are trials where the taxane was given after chemotherapy, so they may compare AC with AC followed by a taxane. So you're giving an additional drug and you're treating for longer. And on the right, trials where you gave chemotherapy essentially for the same duration, but you took one drug out and put a different drug in, like the TAC-FAC trial from BCIRG. 5-FU was removed and Taxotere was put in place. Those are the more recent trials, so the follow-up is shorter, but essentially in the Oxford overview analysis, they both work, and they both give about a 15% additional benefit. The fact that this is a 16% benefit and that's a 14% benefit, I don't think we can say, therefore, that one or other approach is a more efficacious way of using taxanes. Adding a taxane into an anthracycline regime does give you better outcomes, but the benefits are relatively modest. And therefore, the lower the risk, if you're concerned about the additional toxicity, maybe not everybody needs the taxane. And if you look at mortality, which is the ultimate thing we're trying to prevent, you see more or less exactly the same thing. Longer follow-up, a 14% reduction in mortality when you add the taxane afterwards, and a 12% reduction in mortality when you stick it into the regime. So it works, but the impact is somewhat less than some of the earlier trials would suggest. And can you use those molecular characteristics from your pathologist to say who shouldn't get a taxane? Well, no, but if you're tempted to ask the luminal question, it's the luminal Bs who sit in the wrong part. And I don't think that's significantly different, but these data do not suggest that the luminal As don't benefit from taxanes. Irrespective of whether they're HER2 positive or negative, whether they're older or younger women, and if they're ER positive, whatever degree of differentiation, actually they all seem to benefit from taxanes. So it's down to risk and how much the taxane additional benefit is justified in that patient. So as far as we can see, and there are data coming through from newer trials like MINDACT, TAILORx, and others, which may change this in the future. As far as we can see at the moment, chemotherapy appears to work in most of our early breast cancer patients. And so we're still stuck with having to select whether or not to give chemotherapy, mostly based on risk of recurrence rather than on a biological chemotherapy sensitivity predictor, which we would all love to have. So the move towards a biological selection, it sounds exciting, we'd love to do it, actually I think is more difficult than we sometimes realize. If your challenge, therefore, is that you think the risk justifies chemotherapy, but you're concerned about patient morbidity, being gentle by reducing the doses isn't doing them any harm, any benefit. I think we still have to decide either to do it properly or not at all. The one exception might be in the HER2-positive space, as Eric was talking about, but I've not covered the HER2-positive area. Adding a taxane into an anthracycline regime does give you superior benefits, although perhaps the benefit is more modest than we'd initially thought. And personally, I think the data support either weekly paclitaxel or 3-weekly docetaxel. There may be subgroups where it adds less, but they're not easily defined either. But if you take a patient group who had no chemotherapy, add in an anthracycline, and then add in a taxane as well, just missed the last line, which said that, in fact, an anthracycline-taxane combination compared to no chemotherapy reduces that woman's risk of dying by 1/3, which is a very significant effect. Endocrine therapy probably halves your risk of recurrence, chemotherapy on top of that by another 1/3, and that's worthwhile in many of these patients. Thank you.
Thank you, Professor Cameron, for the comprehensive review on the optimum selection of adjuvant chemotherapy. We will postpone the questions till the end of the session for time's sake.
Okay.